All right, so October 8th, welcome. We're going to talk about ultrasound today. This is really for our IVC community. And today, thank Jan Sloves for joining me. Jan's an ultrasound tech that I've been working with for a long, long time. We've written some stuff and done a lot of things together. And what we thought we would do is some of the common questions that people would ask. And these are physicians that scan, mid-levels, physician's assistants, ultrasound techs, um, all kinds of backgrounds. They're learning how to scan a patient using, holding the probe in their hands with live patients. So we're going to start with the basics. So let's, I think what we'll do, I'll hand it over to Jan here, but color flow duplex ultrasound is how most people refer to it. It could also be thought of as triplex ultrasound because there's really three components. There's the grayscale, sometimes called B mode, and that's the actual imaging portion. So the sound waves leave the transducer, they go through tissue of different types and impedances. The sound wave hits the target, reflects back a sound wave to the transducer. The computer does its magic and it generates a black and white or gray image on a colorless image on a screen, black, white, and everything in between. It shades of gray. And those really represent the amplitude of the wave and different characteristics. We'll talk about that a little bit. The pulse wave Doppler is really how you measure it's really blood flow velocity, the velocity of blood, because in this case, the red cells are moving inside of the blood vessel, and it creates a frequency shift when the sound waves hit the moving cells. And using the Doppler equation against the computer will do its magic and generate an image on a screen, a pulse wave Doppler image or spectral Doppler image. And the third would be color flow and assignments of red and blue color. And people think that, arteries red and veins blue. So we typically assign the color in that fashion, but it doesn't mean, it's just a color direction. And then the color characteristic can reflect higher or lower velocities based on the actual depth of the color. So that's a general overview of what triplex ultrasound or color flow duplex ultrasound is, and it really, in my mind, that's what really revolutionized this venous field. Yes, we've got great endovenous devices, but it wasn't until we could actually look inside the leg with ultrasound that we started to really understand what was going on here.
So thank you so much, Jose. So let's get into some ultrasound basics. Sound waves in diagnostic ultrasound are generated by piezoelectric crystals in the transducer. And what these crystals do is they vibrate and they generate sound waves with specific frequencies. And typically in diagnostic ultrasound, when we're looking at the legs, we're using a high frequency transducer, opposed to when we're looking at the abdominal pelvic vessels, we're using a lower frequency curved array type transducer. So diagnostic ultrasound uses waves with a 1 to 20 megahertz frequency band. And interesting enough, in comparison to audible sound in humans, which ranges from 20 hertz to 20,000 kilohertz. Now, typically what happens is as sound waves propagate through tissue, they encounter different interfaces, which can either be reflected, scattered, refracted, or absorbed. And this loss of energy is known as attenuation. Now, the average propagation velocity of sound waves in soft tissue is 1540 meters per second. And higher frequency, when we have higher frequencies, they experience greater attenuation in tissues and therefore cannot penetrate at lower frequencies. So with that, I thought that this would be a great example to share. Now, here we're using a linear transducer. And mode one, this transducer is being operated with a higher frequency mode that provides higher resolution with less penetration. And mode two is the probe is being operated with a lower frequency that provides more penetration at slightly lower resolution. So when you analyze the images, what you can see here very clearly is with the higher frequency, you have much better intimal detail here. You can see that very fine. And in contrast to the lower frequency, you're losing resolution, right? So we're lacking that intimal detail, and you can see how the intima breaks up. Now, to take this a step further, what happens here is that with the higher frequency mode, you can see that we lack penetration with the higher resolution. And over here, you can see, again, using that lower resolution or lower frequency mode, you can see that we have much better penetration with lower resolution. So these are some of the trade-offs and decisions that you would make when you're operating your transducer. Now, when we talk about B mode or grayscale imaging, well, this utilizes the amplitude of the reflected echoes to plot the 2D image. Now, when I'm thinking about these images and creating them, when you're doing your image acquisition and the scan is going on, I always want to create what I call optimal gain. And typically, when you make an image, you want it to be a mixed range of signals that will be low to high in their amplitude. Remember, if the image is too dark and you can't really see your anatomy well, you put yourself in a situation where you can cover up anatomy and disease. And if your gain is very bright, then you're basically obliterating the signal, right? So, the whole idea is when, you're acquiring this information is we need to see the walls, we need to see what's going on intraluminally. Now, here you can see what I call the target anatomy, whether or not it's in short axis or it's a long axis. We need to define this with great clarity. Now, when we're doing this, okay, we also want to be always aware of our overall gain, our TGC, time gain compensation. And this is a very important feature on every ultrasound system because what it does is you have the ability to change the depth of interest from the near field to the far field. And this is, for me, this is one of the most important controls on the ultrasound system when it comes to grayscale imaging. Now, we also want to be aware of the depth in terms of acquiring these images, and we want to always make sure that our focal zone is at the area of interest or just below, because this is going to help provide optimal image detail. Now, let's turn our
So Jan, on that, go back that one slide there. Just go back one. You talked about resolution and frequency being inverse related, right? High frequency for superficial targets and low frequency probe for deep targets. You have to change probes for that, correct? There's the typical linear, what is it, 7 to 10 we would use for the saphenous, and then a convex or curvilinear probe that's 2 to 8, or I'm blocking on the numbers now, but you need to change the actual probe to generate to a lower frequency probe to go deeper. Is that true, or can you adjust the actual frequency with a knob on the machine?
Well, a linear transducer today on most commercial ultrasound systems allows you to change the frequency within that particular transducer. So if you have a bigger leg, you can go into a penetration mode or use a harmonic penetration. If it's somebody with a very small leg, you have the ability, again, to change the frequency to a higher resolution.
So that's
Um,
where harmonics comes in. Is that correct?
That would be where harmonics comes
Okay.
in. Yes,
And that's an adjustable knob on the machine.
yes, it is.
And then gain is usually a knob that one can adjust. And the TGC, you've got the lever action there on the slide that the
Mhm.
operator adjusts also. So a lot of this is operator dependent, is what you're telling us, correct?
Oh, absolutely. And this particular image that you're seeing here, that is the image, and that is the TGC alignment that created that image.
Yeah.
So again, as I stated, a very important control.
So if you're not, putting the probe, seeing the field, and actually doing adjustments as you scan, you're not going to get an optimal image. It's constant adjustment, I'd imagine, correct?
It is.
Yeah.
If you, again, you stated that very well, but yes, I mean, in my opinion, if you're doing this correctly, your hand is always on the controls, changing exactly what you're
Yeah.
seeing from image to image as you go about this and acquire this data.
Yeah, that's important because we'll get second opinions come to the office and I want to repeat the ultrasound in my office and the patient says, why? I already did an ultrasound. And my response is, I just don't believe anything going on out there. That's why, we like to see it ourselves. This is operator dependent. And that's the part that patients need to understand, that it is operator dependent and labs have different skills. And of course, there's machine quality issues too, which we won't get into here, but some machines are superior to others. Anyways, keep going. Let's go. Keep going.
Okay, so now let's go from grayscale, and we'll talk about color flow imaging. So again, in order to have good color, you got to have a good grayscale image because you're going to lay that color over it. And, at the end of the day, color helps us determine blood flow and the direction. So with that, I thought, let's really break down the whole everything with color. So here we have a color map, and I thought this is a great place to start, right? So this color-coded map, it's really about the Doppler shift. So it's located on the side of your ultrasound monitor when you activate and put on the color on your system. Now, I want to bring your attention to this black line, right? So the black line on the color map, this basically separates the positive Doppler shifts from the negative Doppler shifts, right? It also represents that there's a zero Doppler shift when we have black, right? There's no flow going on whatsoever. Now, we also have the ability to change the baseline of this, and we could either shift it up or we can shift it down. Okay. And this is going to depend on exactly what we're doing. Now, shifting the baseline changes whether more or less positive or negative shifts are displayed. So this is going to emphasize either flow towards or away from the transducer, and to help avoid signal wraparounds such as the aliasing effect. Now, shifting the baseline does not change the velocity scale. So again, you could see the black arrow to you could see the red arrow to the area that's at zero flow. So here, when we're going to read this map, red is towards the transducer and blue is away. So what you're seeing here also is that when you look at a color map and you see those higher hues, this is where we're having the increasing velocity. And all maps are basically similar. Their profile may be slightly different, but the essence of it is the same. Now, with that, let's talk a little bit about the color Doppler box and the velocity scale. Now, when we activate the color and the box comes on, it will display color, or we could also use the same format with power Doppler. Now, the velocity scale, typically color is assigned on the color Doppler map to signify different velocities. Now, the further away from the baseline in either direction, the higher the velocity of the blood flow. Now, the number that we see, which is right here, the scale is set at 30, right? So basically, each end of the color bar is going to display this number. And basically what this is it's representing a range of velocities that are displayed on the color map. Now, the range of the velocities can either be changed by adjusting the scale, control on your system. Now, when we're going to read this schematic here, you can see that the yellow line here represents our beam. And you can see how this box is steered, right? So in this particular instance, we have red towards a transducer as we see this vessel color-coded in red, and blue going away from the transducer. Now, with that, this is subject to change. Now, here we can see other schematics where we're documenting flow towards the transducer. So when we look here, again, this represents the ultrasound beam. So basically, the blue now is color-coded towards a transducer, and you can see how this vessel now is following in this direction and how the color box is steered, right? So we have basically a positive Doppler shift in this respect. Now here we can see how the beam is coming down. And in this particular schematic, now flow is color-coded in red. Red is towards the transducer, and we have a positive Doppler shift here. Now here we're going to put both in motion. And again, here's your yellow line that represents the beam. And now what we have is blue. Well, I should clarify here, we have red towards a transducer and we have blue going away from the transducer.
All right. So Jan, let me interject because this is where people start getting confused. So the transducer is sitting on the skin, and the waves, the sound is being penetrated deep. But these blood vessels are oriented, um, as you can see, horizontally there, and they're at an angle. So when you steer the box and you've got the yellow line that's outside the box, one pointing down. So as you can see, if you follow with your finger the yellow line pointing down outside the box, if that line stays outside the box, that's what we call towards the transducer, or where the transducer side is. If you were to put the yellow line pointing down on the opposite side of the box and start in the upper corner and put your finger straight down, it's going to go inside the box. So that's not where the transducer is. So some people call it home. So you've delineated there that yellow line pointing down as home. That's where the transducer is. And then if you look at the color bars, on some of them, the blue is on the top, and on others, the orange is on the top. But that also doesn't really tell us where is the head of the patient or the foot of the patient. And that's a different. So on the ultrasound screen, when you look at it, usually there's a company logo on either the right or the left. And on the actual transducer, there's a notch that you can feel that orients the actual probe direction to the company logo. And that'll tell you cranial caudal direction. And then you can kind of assign as you steer the probe, okay, if I want the artery to be red and the vein to be blue, or reflux to be in a reflux in a vein to be red, you can set that up yourself based on, the way you're turning the transducer and the orientation of the actual vein. So you're steering parallel to the way the blood vessel lies. Is that correct? Or maybe you can explain that a little clearer.
No, actually, I thought you articulated that very well. Exactly. And we will, and some of the points that you just made, as we get a little bit further in the orientation of the color, some of these points will actually be, further made. But
Yeah.
yeah,
Okay. All right. So let's keep going. Maybe we'll just
yeah, I
keep
mean,
harping on that because, when you've got somebody standing now, some people scan with the saphenous vein and short axis and try to determine reflux. And of course, that's not the ideal. But then you lay him down, and then the folks are asking you, well, which way is the head? Which way is the foot? Why is the artery blue here? Why is the vein red? How do I steer the box? What do you mean towards the transducer? The transducer's on the skin. What do you mean towards the transducer? So that gets confusing for people, and even the left and right and up and down, they can't orient with the probe in their hand.
no, it's good points. I mean, these are some of the questions that we fielded when we were doing the hands-on. So with that,
Yeah, so as that, try and frame the next few slides with that in mind, if you can, as you go through these.
yeah, sure. So, again, these schematics here basically demonstrated flow towards a transducer. So now let's do the opposite and talk about flow away from the transducer, right? So here in number
And can
one,
you point with your mouse there, Jan? Just an arrow with your mouse or no? Or your
I don't have an
you don't
arrow.
have that. Okay, that's all right.
Yeah, that's why I put up the arrows with the yellow.
Yeah, it's all right.
Yeah. So anyway, in the schematic one, here we can appreciate that red is towards a transducer and blue is away. And we could see how the box is orientated here and how the beam comes down and how we have flow going away from the transducer. So we have a negative Doppler shift, right? Blue represents flow away from the transducer. Now, in number two here, we could also appreciate how we have the beam coming down and the box is steered. And now it's basically the opposite, right? So we have red, basically going away here. So it's below the baseline. And now again, we put both together, and here's the beam coming down, and we can appreciate that red is towards a transducer and blue is away. So again, as you spoke about, this is subject to change during the course of your deep and superficial examination, the way you're going to position the patient, the way you're going to hold a transducer. Again, patient is in the reverse Trendelenburg position, and you're insunating different vessels, and then you're going to stand the patient up. So again, you always have to pay attention to the direction of flow. Now, another really important point here is the color box steering. Now, here in number one here, you could appreciate that the box is basically it's what I call unsteered, right? It's square. So it's perpendicular to the ultrasound beam. So what happens often in this particular scenario, and I do have some examples a little further out, where you don't have a Doppler shift or you have very limited amount of color signal there. Um, and um, and that could be problematic because if you acquire images like that, one could, somebody who's interpreting that could think, depending on the scenario, that there may be something going on intraluminally there where you don't have, color filling per se. In number two here we can see how the box is steered, right? The flow direction moves towards the ultrasound beam, right? So we got the vessel color coded in red and it's towards the transducer. And then here we can see that we have a negative Doppler shift. We have this vessel color coded in red. Again, red is below and blue is on the top. So again, subject to change. And as the operator of the ultrasound system, we have the ability to make these changes, based on what we're seeing when we're doing these clinical examinations. Now let's talk about color flow Doppler and the invert button. So certainly when you're doing this, the operator can flip the colors assigned to the positive and negative Doppler shifts on the color map. And with this does not change the direction of flow. A color map will always display positive Doppler shifts on the top of the color map, above the baseline, and a negative Doppler shift on the bottom of the color map below. Now, now with that, when we look at these two schematics, here we can appreciate the beam coming down. So what's happening here is we have the red is on the top, right? And this is flow towards, and blue is away. And then here we have basically have inverted the same information. The box is still steered the same way. So here we have flow towards, color-coded in blue, and red is going away in this particular manner. Any thoughts about
And
this?
then why would you want to do this? Just to assign an artery red and a vein blue, just for conventional, so people looking at it? Why would you want to invert it?
Well, there are times where you're looking at, well, first, we were kind of taught, right, that you want to keep arteries red and veins blue, right? But, you have again, you have depending on how you're steering your transducer and the way that you're going to insunate these vessels, it is subject to change, right? Um, so I think even if you're in a situation where maybe you're dealing with a couple of vessels that are tortuous, and now all of a sudden the vessel's going in a different direction, subject to change. We certainly see that. I do a lot of arterial work where all of a sudden you have loops and curves. You have situations where veins are very tortuous. So, this is not uncommon to see this. And then, you're going to have to, invert and make these changes, to make sure that you are following the correct direction of flow that you're trying to assign.
Yeah, so when the reader, which is not the person, doing this often, a radiologist or whoever's interpreting the study is generating the report,
Mhm.
uh, in their mind, they want to see the image set up where the artery would be red, the vein would be blue, and a refluxing vein would be red away from the probe, just out of convention. Is that correct? That way they don't have to be digging into each image, looking at the color bar, looking at the direction, seeing which side the transducer is on based on steer, doing all the the work to interpret that image that we just described. They just kind of want to look at the image and here's the velocities. This red is artery, vein is blue. Is that kind of the way you guys are thinking as you're doing the study, trying to make it easier for the interpreter?
Yes. Yeah. I am, I feel strongly that when you're insunating a refluxing vein, typically when you see that, the vein itself should be color coded in red when you're going to acquire those images. So I agree with that 100%. And often what we see out there is that's not always happening. You're seeing a blue vein and then you're seeing
Yeah,
a lot of reflux.
yeah.
Okay, so now let's talk about some of the pitfalls, and there's quite a few. So these are things that will produce erroneous flow direction information, right? So if the operator flips the direction of flow that are assigned to the positive and negative Doppler shifts on the color map, so it is important to pay attention to what color is on the top, as to the display. So a positive Doppler shift at the top of the color map and negative Doppler shift at the bottom of the color map. So again, here we can see the beam, and then here we can see blue is towards a transducer and red is away. And then here we can see the beam, and basically now we have red towards a transducer and blue away. So to take this a step further, some more pitfalls. So how about when the color box steered opposite direction of the way the vessel lies? And you kind of spoke a little bit to this earlier in this conversation. Now, if the operator steers the color Doppler box in the opposite direction that the vessel is angled, the flow information will invert. As a result, the flow that's moving towards a transducer will suddenly be represented as flow that's moving away from the transducer. And the flow direction in the vessel hasn't changed, but the ultrasound system shows incorrect flow direction because the ultrasound beam is directed the opposite direction as the vessel angle. So here in this particular instance, we can see that the vessel here is towards a transducer and the vessel on the top is away. And then here we can see the beam and we can see how now the box is not steered appropriately. And I do, when I go out there and I visit labs from time to time, I do see acquired images that look like this. And you know, it's incorrect. Let's take it another step. So again, we're talking about pitfalls here. So how about the color box not steered when evaluating a vessel, right? A perpendicular flat vessel And an unsteered color box will produce no Doppler shift, no color Doppler angle, right? So here we can see the beam. And now we have a longitudinal vessel going through a straight box, right? So this is where you can now start to have some error. So again, steer the box, right? Heel toe the transducer. Again, I'm really believe that who is the operator of the ultrasound system and you're holding a transducer, you have to have complete control of that instrument to be able to steer the vessels and create, proper Doppler shift by being able to, create these images for color flow and for pulse Doppler.
So, Jan, is this image, so this is color flow. I don't know if you're going to talk about pulse wave Doppler later on, but uh, as you know, with pulse wave Doppler, you get a sample volume inside of the blood vessel, and it has to be at an angle. 60 degrees would be the conventional angle because the Doppler equation dictates that sound waves hitting a target perpendicular to the target, perpendicular to flow generates it's zero. So you won't get any frequency shift. So by convention, you need to angle the ultrasound beam so that the reflected image generates an image. So if is this kind of analogous here that the steer of the box is analogous to adjusting the cursor inside the sample volume with pulse wave? Is that similar concept?
It is. It really is. Exactly. And we're going to talk a little bit about pulse Doppler a little further out, but yes, exactly. And interesting enough, the ultrasound manufacturers have come up with some ways to, from an engineering perspective, to further be able to steer the box. Some of these companies refer to it as intelligent steering, if you may, where as I'm showing these schematics, you're either to the right, to the left, or straight on. But many of these manufacturers now with the newer systems give you the ability to fine tune this, that you could actually, in some cases, have a vessel that's going straight across, but the way that they're able to align the Doppler angle and still create a 60-degree there for us, is now happening. It's been for a while, and so we'll get into that a little bit further out. So just to further hit home this point here, again, it's about steering the box, heel toe the transducer. If you're having difficulty, change your scanning window. You need to be able to produce that angle so you get your Doppler shift, again, whether it's color or pulse Doppler. You need that information. So in the area of interrogation, here you can see in the schematic, when it's perpendicular to the ultrasound beam, there will be no color Doppler signal. And you're not going to get, the information really that you need, right? Because, there is no Doppler shift at 90 degrees, basically. So that's that point. Now here, this kind of takes us back, in terms of practical life for us, as we're seeing patients. And, I created these images, and here you can see with improper box steering, we lack color information here, and the scale is low enough. It's at 7. And then here you can see by just making that change of the color box, the vessel fills beautifully, right? So your optimal color flow is obtained at angles closer to 0 or 180 degrees. So again, this is a completely normal vessel, and this is what we would expect. A couple of other thoughts as we start to wrap up color, again, about the color box. I typically like to use a smaller box. I don't like to use a box that's going to fill up the whole size of the picture that I'm seeing because the bigger the box, it's going to slow your frame rates down. And you also run the risk of the color then bleeding out as I'm showing you here, right? So here we can appreciate a vessel that was acquired and there's just not enough gain there. And then this is too much gain. Again, no matter what you're doing in ultrasound from the head to the toe, you never want what I refer to as messy or sloppy Doppler, right? When that color bleeds into the tissue like this, you run the risk of covering up anatomy and disease, and you don't want that. You want to be able to make sure that you're very in tune with your controls as it relates to your color scale and your color gain. And remember, when you lower your color scale, this is going to increase your color sensitivity. And when you increase your color sensitivity on the pretenses of wanting to fill a vessel lumen, as you can see here, right? Again, when you lower that, you're then going to have to back off, decrease that color gain. And I think that this is a very nice example that kind of just really illustrates the difference from undergain, overgain, and optimal gain. Any thoughts with this, Jose?
Yeah, no, that one's straightforward. Adjusting the gain with the button. That's an easy one for people.
Yeah. Okay, so now let's talk about using color flow to determine reflux in a transversing image. Now I can tell you, so basically I made a couple of points here, right? So, transverse and pulse Doppler assessment does not allow the operator to ensure a favorable Doppler angle in achieving accurate diagnosis. It just doesn't. And, the approach may work in a grossly dilated vein, with gross incompetence, it may. I think the bottom line is, in the smaller vessels with very slow reflux, poor Doppler angle, this is going to result in, a dramatic further reduction of the already small Doppler shifts, making flow difficult to detect. And, interesting enough, it's one thing to make these points. It's another that, I recently had a patient that has long-standing atrial fibrillation. And now you're trying to, if you're going to look at that and you think about, the elevated heart pressures and all, and now you're trying to make the determination in cross section. I mean, it's just very, very difficult to do. And I just think that, you want to do the right thing by the patient. You want to have an accurate diagnosis. And I just think that in the end, it's best served when you're looking at the vessel longitudinally. If you want to use the color as a screening tool to be able to see in that particular instance, if you, with distal augmentation at the calf, to get that change in color and to see if that is indeed, there's valve failure there and that vessel's refluxing, that is fine. But in terms of making an absolute determination of reflux, again, you need pulse Doppler, and we want to use, whether or not it's greater than 0.5 seconds and 1 second in the deep system, and you want to document, reflux appropriately in your scans.
So the transverse view, and we all use it because it's kind of quick and dirty. So I think you just use the term screening tool. So you have somebody standing in front of you, you look up and down transverse, and with the color box on, and you squeeze the calf, and you don't see reversal of flow. It may be there. So in that case, you'd go longitudinal and try and really interrogate it with the pulse wave Doppler. But if you do see reversal of flow in the transverse, you can feel pretty comfortable that there's reflux there, correct? So it's sensitive, or sorry, it's not sensitive or specific, but if it's present, you're usually confident that there is reflux if you do see reversal of flow in the transverse view. You can't get a reflux time, but at least you can kind of see it's there. Is that accurate or no? Or you should go longitudinal always?
If I'm just going to be completely honest, I don't even use it. I use the transverse view to measure the diameters.
And that's it.
Obviously, if I put the look, if I'm looking at a real C2 patient and I see that there's bulging varices, I mean, I know what I'm going to expect when I put the transducer down.
Yeah.
So for me, there isn't a lot of time to complete an exam, and I'm not even going to really honestly waste my time with that. To me, it's always about, at the specific levels, where does the reflux start? Where does it end? What is the vein diameter? What is the reflux time? And
Yeah.
what's going on anatomically. So I particularly don't use it.
Yeah. If you're the one doing the exam and documenting, yeah, you have to do it all, correctly by the book to get accuracy. But for us who, I've usually got an ultrasound exam in front of me and I'm just kind of mapping up and down to see what device I want to use based on the characteristics of the vein. Sometimes my techs won't detect flow on somebody with C2, and I'll just kind of go up and down and squeeze myself. And sometimes I'll find reflux they didn't, or vice versa, but it'd be rare. But usually theirs is more accurate than the longitudinal is more accurate than the transverse. Is the point we're trying to make here for
For
detecting
sure,
flow. Yeah.
for sure.
And while we're on that point, can you do a superficial exam laying down, or does it have to be standing?
Um, it's got to be standing. I can tell you that if in my lab, if you walk in the door, you're going to stand for the exam. I mean, it's really that simple.
Yeah, and it's amazing when the patients tell me that they got an exam elsewhere and the whole thing was done lying down. It's still going on out there. I just don't understand it.
It is, and it's wrong.
But you have to challenge the valves. The only way to challenge the valves is gravitational. They have to be standing.
Correct.
Now, is that the same case with the deep system?
Yeah, I feel the same way about that too. Sure. So basically, when I'm going to do an exam, I get the patient in the reverse Trendelenburg, like 15, 20 degrees. This is where I'm going to get all my compression. And at that point, I also get the bilateral common femoral vein waveforms because I'm looking to see if there's any differences in the quality of those waveforms for asymmetry purposes. And, of course, in the right patient to see, and, that's a kind of screening tool for me to see if they may have an outflow obstruction. But after that, for the determination of reflux for the deep and the superficial, they are standing.
It has to be standing. Yeah.
Yeah, I'm a stickler for that.
Yeah. Good.
Yep. All right, so let's now talk a little bit about pulse wave Doppler. So here again in this schematic, you can see the transducer, and typically what happens is here we have, basically what's happening is you have these crystals. It sends and receives the signal, right? So the signal's intermittent, it's on, off, on, off. So there's a sending time and a listening time. And the transducers of today, I mean, this is all done very quickly to produce a real-time image, right? So the crystal must wait to receive the signal back before it can transmit another signal. And of course, with increasing depth, there's a journey time. This increases the round trip time that it takes. And the crystal must wait longer for the signal to return before another pulse can be sent out, right? So it's the basis of ultrasound. We've already spoken about what constitutes the triplex ultrasound, grayscale, beam mode, color flow, and our spectral Doppler information. Now, with that, there's a few things that we need to know. And certainly, whether we're looking at the arteries or we're looking at the veins, we have control of all of the pulse Doppler settings on our ultrasound system. And these are settings that the operator needs to know because you're going to be making changes to them through the duration of whatever examination that you're doing, right? So what I want to talk first about is this horizontal line here, which basically is the middle of the spectrum of our waveform tracing. Now, basically, what this represents is an area of zero flow, right? No Doppler shift, and it separates the positive and the negative Doppler shifts that we encounter when we do these exams, right? So certainly we can move this up or down to accommodate, higher or lower velocities. And, certainly that happens to us when we're looking at, the lower extremity arteries, right? That's going to change through the duration of what we're seeing. And we need to display this information clearly so we can look and appreciate, the quality of that wave, again, whether or not it's a triphasic, biphasic, or monophasic waveform. But we also need to pay attention to this when we're doing our vein exams too, right? Because when we're going to be looking and, encompassing patients that have reflux, some of these reflux waveforms are going to be high velocities where we're going to have to make these adjustments. Some of them are going to be low. Some of the durations of the wave of the reflux is going to be short and some of it's going to be long, right? So all of these controls come into play, right? So moving the baseline does not change the velocity range itself. Rather, it changes whether a higher number of positive or negative Doppler shifts are displayed on the waveforms, which can eliminate the wraparound of the waveform tracing, right? So now a waveform pattern above the baseline represents flow moving towards a transducer. So that's a positive Doppler shift. And then a waveform pattern below the baseline represents flow moving away from the baseline, a negative Doppler shift. Now, arteries tend to be above the baseline and veins typically below the baseline, right? But, it's not always, right? That is subject to change depending on what we're looking at, the way we're holding the transducer, right?
So
Some
same principle as color, right? The color bar above, the black line in the middle, the color bar below, detecting towards or away from the transducers. Just one is displayed with color, and the other one with spectral, a spectral Doppler they call it. Is that correct?
That is correct. It works on the same premise.
And
Yes.
then what you're, I think, getting at the wraparound or aliasing is that's when the Nyquist limit. So if your scale or your PRF isn't set properly, the I don't know how to describe this well, but there's the pulse repetition frequency sent out by the probe has a certain limit, and if the reflected frequencies from the probe exceed the what was sent by the PRF by what I don't know how to describe it. It's easy I think you have a picture of it probably what aliasing looks like on a scale because it's hard to describe the actual physics of it.
No,
But
you
see it,
actually,
it's obvious, and how to adjust it is obvious.
yeah, I don't have a picture of the aliasing, but you actually described it actually very well. So basically, it exceeds the limit, and what happens is that waveform then, because it's based on how your scale is set, right?
Yeah.
Set. So then it just wraps around the baseline. So the whole idea is to make these adjustments to the scale and the baseline, so we can display the information, this spectral Doppler information that we want and we're going to make decisions on, right? Because it's very important information, again, whether it's arterial or vein, and we want to be able to display it accurately.
And then the real value, at least for veins, so you'd ask the question, well, spectral Doppler and color Doppler, they're kind of giving you the same information. It's just different displays. Really, the only way to detect reflux time is with the spectral Doppler, where you actually see the flow above or below the baseline, and then the time is moving laterally, what you call the sweep speed, right? Adjusting the sweep speed will kind of let you know based on the sweep of the spectral Doppler going left to right on the screen, how much time elapses between the shift from negative to positive again. Is that correct?
Yeah. So I often change the sweep speed because, when you're measuring reflux, right? So what's interesting is that the operator has the ability to change the sweep speed on any given ultrasound system.
Yeah.
Of course, the manufacturer makes a preset for, lower extremity vein. And depending on this often happens where, the manufacturer has this set fast, or
Yeah.
medium in terms of the speed. And what happens is that you encounter reflux and then you're not, it's going too fast. So this way you're not being able to depict the entire length of the reflux. So typically when I'm doing a reflux study, I set it low, or the lowest that's allowed, that's attainable on the ultrasound
Yeah.
system, right? So then or I should say, the most minimal or slow. So this way, I'm able to measure the entire length of the reflux. That's really the point here.
So to get the velocities and the reflux time, that's really where the value of the spectral Doppler is. You can't really do that just with color only.
Correct.
That's accurate, correct? Yeah.
Correct. Right. So that means that the operator, just to kind of summarize this, the operator needs to be able to change
Yeah.
their scale appropriately, and shift the baseline,
Yeah.
and also change the speed in which they're acquiring that information so they can measure the entire length and the duration of reflux accurately.
Yeah.
So now let's talk about spectral Doppler invert. Um, now, um, Now when you press, we all have an invert key on our ultrasound system. And this is going to invert it, to either a positive or negative Doppler shift, right? So this control will flip the velocity scale on the spectral waveform tracing display, a negative Doppler shift above, and below, and positive shifts. So you really want to be aware of what you're pressing, when you're doing this, right? Because ultimately, you want your color information and you want your spectral Doppler information to be in the same direction of what it is you're doing. I mean, that's an important piece,
Yeah.
right? And so that's really the point here when you're doing this. Now, let's talk a little bit about the Doppler angle. And you alluded to this at the very onset of this podcast today. And I think that this schematic here really nails the points, very well. So the angle from which the spectral sample is obtained, right? An angle of 0 degrees is ideal, but usually not attainable, right? Now, when does zero work? Well, for us that have done, many echoes, right? The way your ventricle and your atria on your right and left hearts, the way we insonate this in cardiac ultrasound, and the way that the valves open, this is kind of how we work, right? We work straight up and down. So we're using, we don't put an angle on that. But with vascular ultrasound, that's a completely different story here. So angles from 0 to 60, they provide accurate Doppler shift information. Now, angles above 60 degrees, so 61 through 89, this provides errors in the velocity. And what it's going to do is it's going to overestimate the flow velocities. Now, the larger the angle, of course, the greater the error. An angle of 90 degrees will provide no flow information, no Doppler shift. So we want to align the angle in the center of the vessel in the direction of flow. So here we can see where I brought that arrow up at 60 degrees, and you can see how the vessel is steered. And you can appreciate here the way that we're going to insonate this vessel. And now when you look at this, this image that I have here below, here you can see that I'm using a 60-degree angle, and you can see the sample volume and the angle is in the middle of the vein. And this is a vein that's actually, we're in the pelvis here across the iliocable confluence. This is the left common iliac vein being compressed by the overlying artery against the spine, and you can appreciate the high velocity here of over 100 centimeters per second, right? So this is what we refer to as venous stenosis here. So again, this technique in terms of placement of our spectral Doppler, along with our sample volume and our angle is vital to, the quality and the accuracy of our examinations. You want to make a point here with this,
Yeah, I was going
Jose?
to say, there's actually a ton on this slide on the image, the Doppler image. Um, so number one is a curvilinear probe. So the where is the transducer? So it's a little different because in this case there's a color shift away from the midline. So you have to know how to interpret the curvilinear probe uh, flow direction, which is a little different than what you described with a linear probe. You're still using the color bar as a guide as to or away from the probe. And then the other thing on the pulse wave Doppler, you see um, the velocity negative Doppler shift below baseline up to 120. The scale is set at 120. If you had this scale set at 60, for example, this would be what we were talking about, that the signal would actually wrap around above the baseline and alias because it was set improperly. And this is what we see in more of a continuous flow versus a phasic flow. We'll get into this with the next, uh, you know, round two on the ultrasound series we're going to do because we're talking about the basics here. But the point is, if you look carefully and you start looking at the numbers, your PW at 40%, color flow 52%, um, the 40 hertz at the upper left. There's a lot of operator input that needed to occur to generate this image. And then you're really getting a ton of information once you learn how to interpret this just by looking at the image.
Right. So basically so why is that 40 hertz? Well, you can also appreciate, yes, this is a curved transducer, but you could see that the field of view is very small, right? So
Yeah,
if that field of view was opened up really big, those frame rates would be a lot, they'd be
right.
a lot lower.
Lower. Yeah,
So again, when I think, about constructing an image and interrogating a vein such as this in this particular instance, I'm not really interested about anything else that's going on but that area. So for me, I want the fastest frame rates. You could also, you were just talking about the color bar, reds towards blues away. You can see that the intonation of this vessel, it is color coded in blue, and the overlying vessel is color coded in red. And what I also want to point out here is that we talked about the higher hues of the velocity of the color bar. And we can see that we have the color scale, at 18. But again, because there's such a tight stenosis there, this what's happening is that again, that velocity is high, and that's why you're seeing the aliasing effect within that vessel, right? Because that vessel is basically pancaked in there.
yeah,
But, you made a great point too, that if the scale was, not, it was brought to 120 to encompass, the velocity. If that scale was 50, indeed, it would be wrapping around and you'd have a complete mess of your spectral Doppler information.
yeah.
These are the basics.
Yeah,
So,
we'll probably need do a whole different podcast on deep imaging because what went into that image was a lot of experience you can see.
yeah. Okay, so again, just to reiterate, 60-degree angle, and you can kind of get an idea here of the
I
vessel.
guess one more thing, Jan. So one could use 30 or 60, correct? But by convention, the vascular world uses 60. But you could use 30 or 60. You just can't use 90 and zero is just unachievable technically. Is that pretty much my understanding?
Yeah, I don't use 90 much. Although, again, as I said earlier, that some of the ultrasound manufacturers have this very fine steering. So basically, your angle, is going to be very steep. And, the engineers are clever. They found a way to kind of
Yeah,
be able to do that. And the only time that I would basically use 0 degrees would be typically when I'm doing that, I'm doing a carotid ultrasound, and all of a sudden, the internal carotid
works.
arteries come across, and then all of a sudden, it just goes straight away from me like this. And that would be, really the only time that I would typically do that
Yep.
in my practice. Okay, so let's talk a little bit about the Doppler effect. So what I tried to do here is make it the most simplest to basically understand here. So, the Doppler effect is a shift in frequency of sound waves due to the relative motion between the sound source. And I got some words covered up here. And in terms of the red blood cell, the observer and the transducer, you know, uh, the ultrasound transducer basically sends out the sound waves of a particular frequency, which is the transmitted frequency, and it listens to the echoes. When the target, moving in the red blood cells is returning the reflected frequency, and it's called the Doppler shift. And then the four things that we really need to have an understanding of is, of course, the transmitted frequency, the velocity of the blood flow, the angle of insonation, and the velocity of the sound in tissue. And, I just want to make a note here that the angle, is the only thing that really challenges in this equation, and the rest is almost constant. Cosine of 90 is 0, which makes the Doppler shift 0, and the cosine of 0 is 1, which allows the maximum Doppler shift. In other words, when the angle of insonation is perpendicular to the vessel, the flow is not detected well. And if the ultrasound beam is parallel to the vessel, you get a maximum flow detection. So, with that,
The
uh,
velocity of sound in tissue is kind of it's 1540 is what they set it at, right? It's
yes,
kind of a mean because bone and fat and muscle, the propagation velocities will differ between those tissues, but I think they just set it as a constant at 1540.
correct.
Yeah.
Yep. So here's a just a nice schematic, basically just showing how the equations used, and how you have the reflected blood flow coming in. So, what's interesting, and we don't really use the equation because the ultrasound system basically does all this for us. But the concept is just really
Is to detect
incredible.
velocity. I
It's
mean,
incredible.
that's really what it's for,
Mhm.
just to detect velocity, speed of motion.
Mhm.
And you need the angle to do that. That's really all it's saying.
Correct.
For grayscale, you don't need it. Color is kind of built in there by steering, but it's the angle that needs the frequency shift needs to be generated at the angle. 60 would be the conventional, as we stated.
Yep. And I think when we put it all together, you know, I think this kind of summarizes a lot of what we said here today.
Yeah.
So, here we have a refluxing vessel. It's color coded in red. It's towards a transducer. And we can see that the duration of reflux is above the baseline. So all of that kind of comes together, right? So we got that sample volume, 60-degree angle, color coded in red towards a transducer. Waveform follows the to encompass the entire duration of the reflux. The minimal sweep speed was used. The scale, you can see the baseline is in the middle of the spectrum. and we have 30 on either side. So again, we don't have this waveform wrapping around the baseline. It's clear and it's precise, exactly depicting, 9.5 seconds of reflux.
And then you see that little blue circle on the upper left corner of the image. So that's telling you that the head is to the left.
Correct.
So the reflux, you say is towards the transducer, but it's away from the head of the patient. It's just
Correct.
the way the color steers. That's what confuses people.
Hmm.
All right. Yeah, I think that's a pretty good start to this. Basics of the differences between grayscale, pulse wave Doppler, and color. Color and pulse wave Doppler really are the same thing, just represented differently. Even though color is giving you velocity based on uh, the quality of the color at the upper or lower end of the bar. Like in this example, the top of the bar is kind of yellowish, representing a higher frequency of what it'd be, up to 480 centimeters per second if it were yellow, which it's not. But if you really want to measure velocity, time, velocity, speed, and duration of reflux, I think the spectral Doppler is the easiest way to go. That's why it's right underneath. And just use the color as a way towards or away from the probe. Of course, you got to know where the head is, and that's that little blue P on the upper left corner. And then you see all the settings. The sweep speed is low, so your frequencies don't get all bunched in there in the I'm blocking the term, Jan, when the spectral broadening. So spectral broadening on a carotid is just the amount of
Gain.
information inside of the window. Spectral broadening is almost I guess we don't. This is just going to confuse things. But sweep speed to get the duration of reflux accurately. Let's just leave it at that. And you got your 60 degrees, you got your reflux time, you got your scale, you've got your steering, you got your Doppler scale 30 per second. There's no aliasing, there's no color bleeding out of the blood vessel. So your gain is all correct. Yeah, I think you got it all here. On
Well,
the grayscale, you see the quality of the vessel wall, the resolution. That's appropriate adjustment of gain on the grayscale. You want to take us through the numbers on the left side of the screen, Jan, real quick? L12.3, 24HZ, 2D. What does all that stuff mean?
so what the information that's here on this engraved on this image is your linear 12.3. This is the transducer that I'm using. The 24 hertz, this has to do with your frame rates. And then you have your 2D information. So basically your dynamic range, operating the transducer with basically a general harmonic frequency, your color flow. Is it 26%? It tells you the hertz, your wall filter hertz, and then your PW information. So, basically every single manufacturer and when you activate your grayscale, color flow, and pulse Doppler, all of this is always engraved on your image. So when the operator is doing these scans, you need to be aware of all your settings all the time. And again, you want to always use, proper technique and really get high quality diagnostic imaging and make sure you always answer the clinical question on your patient accurately.
Yeah. So the left side of the screen, the top is the actual probe.
Mhm.
2D is grayscale information. CF is color flow information. And PW is pulse wave information. Triplex.